Hi, this is Pete Fernbaugh. Welcome to Trinity Talk. My guest today is Dr. Juergen Kloo. He's a cardiac electrophysiologist who just started here at Trinity Health System back in September. So welcome, Dr. Kloo.
Thank you. It's great to be here.
Excellent. But you are originally from Pittsburgh, correct?
Originally grew up in Pittsburgh.
Yeah.
I moved here, in 1991 originally, and then stayed here, graduated from Sewickley Academy right outside of town. Though, from 2010 on, when did I graduate? I graduated high school in 2006. So from then until this fall, I've been, my parents have been in town, but I've been away. So
Yeah.
It's nice to have a bit of a homecoming.
So your education basically took you away for nearly 2 decades.
Yeah.
Just to emphasize how much work it takes to get where you are.
It is. My field in particular has a lot of training.
Yes, so tell us about that field. So cardiac electrophysiology.
Yeah, it's a mouthful.
It's a mouthful, and it sounds immediately impressive.
It does, or like terrifying if you're a patient, I think.
Well, a little bit of both, maybe. Yeah. So tell us. So to make it less terrifying, tell us.
So basically, I completed a full cardiology specialty. You've spoken to other cardiologists before, and many people know what cardiologists do. They're the heart doctors, and I basically took it a couple steps further and did a little bit more training, specifically dealing with the heart rhythm itself. So it could be fast heart rhythms, like atrial fibrillation or SVT many patients have. It can be slow heart rhythms like bradycardia, where you need a pacemaker. So I'm basically a specialized cardiologist that does mostly surgeries to try to either bring your heart rate up or slow it down.
Massively important, massively necessary. Yeah.
Good quality of life thing to have.
Yeah, absolutely. Steady heart rate. Yeah, it's pretty good. Last I checked, anyway.
Yeah.
So, what made you want to go? You could have stopped at any point along the way and had less education, less student debt, less all. What made you? What drove you in the direction of it?
Good question. I think it was always something I was interested in the back of my mind, even through medical school. When I went to medical school, I thought for sure I'm going to be a surgeon. Wasn't sure what kind of surgeon, whether it was like orthopedics or general surgery or something like that. And then I did my surgery rotations, and I was like, I don't know if I like this. I don't know if this is for me. But I still liked being in the operating room and doing that kind of thing. And in my 4th year of medical school, which is our last year of medical school, where you kind of get to rotate on weird niches in medicine, I got to do a month on electrophysiology, a specialty even as a med student I had not heard of or knew what it was, and got to see what the electrophysiologist in my med school did, and basically shadowed her for a month, and I loved it.
So you went through 4 years of medical school, or nearly 4 years before you found out what your specialty is.
Exactly. Yeah, I had figured out by the end of 3rd year I was going to do internal medicine, which is kind of my root specialty.
But still didn't feel quite right.
And all through my postgraduate training, I would do, I would think, do I want to maybe do critical care or pulmonary medicine? No, but I still liked electrophysiology so much. So I'd kind of meander around the course and find my way back. When I did cardiology, I would think, do I really like interventional cardiology, putting in stents, being a plumber, as I put it? But I would find my way back to being an electrician in the end.
So that's a great way to put it.
Various brief tangents, and I kind of redirected and stayed on the course.
So what about being an electrician for the heart?
Yeah.
What about that? And I think that's a great way to relate what you do to someone, like myself. That's
often what I tell patients is they'll, all of my patients come usually from another cardiologist, and I say, they're your plumber, I'm your electrician. We're both cardiologists, but focusing on very different things.
That's a great way to distinguish. So what does that mean to be an electrician for someone's heart?
So for a lot of it starts with the EKG, a test that's routine and easy and that almost everyone's had at some point. And from that, I'm able to diagnose a lot of conditions that could be corrected with something like an ablation, where I actually go inside of your heart, burn abnormal circuitry, is a good way of thinking of it, and kind of restoring your heart's normal rhythm. Or if your heart has aged and you've had disease develop in the normal conduction system of your heart, the normal wiring that's supposed to be there, I can put in a pacemaker or a defibrillator to try to correct those kinds of problems. So
was that kind of what attracted you to this specialty of cardiology, subspecialty, I guess it'd be?
2 things give me the most. I have 3. I'm going to give you 3 things that attract me most to the specialty. One is I just love EKGs, which is our baseline test. Ever since I was a med student, I was a big nerd about it. I've read as many books as I could get to I just love that test. You can diagnose so much from a simple like page with a bunch of squiggles on it.
Well, when the general public knows what it is,
yeah, exactly,
that tells you how important it is. Yeah.
So that's one thing. Two, like I said earlier, I like to be in the operating room, and this is a specialty that lets me kind of be in the operating room half the time, but also be in clinic half the time.
Yeah.
And that kind of gets to number three. I really like the work balance I have. Everyone knows about work-life balance, how much time you spend in work and out of work, but especially for doctors like myself, there's a work-work balance. How much time you spend doing operations versus getting to talk to patients in the clinic versus getting to, have patients wear monitors and read that kind of thing. So it's a nice specialty where I get to be a surgeon, but my patients, most of their diseases aren't cured overnight, and it's a chronic thing. So I really get to know people for a long, long time and see how much what I do gives them long-term benefit. Whereas like if you're an orthopedic surgeon, their knee hurts, you fix the knee, it's great, you get that immediate benefit, that's great. I like getting to develop a long-term relationships with patients and really see long-term outcomes.
That's why you're such a good fit here, because as I'm sure you've learned, the system is all about relationships, especially with the patients and their families. One of the reasons you were brought here, by the way, you spent how many years in Philadelphia?
9 years training in Philadelphia.
9 years.
Yeah, so including med school, it's 13 years to get.
You went to Boston for?
Went to Boston College for undergrad, Tulane in New Orleans for medical school, and then I worked at Thomas Jefferson Hospital and Temple University Hospital in Philadelphia.
Oh my gosh. So moving here to the Ohio Valley, I guess when I look at that, I'm like, well, why wouldn't you stay in the big city?
Sure.
And talking with you before we started recording this, I got the feeling you almost were going in the direction of why would I? Because what did you see here that appealed to both the family man and the nerd in you and the highly intelligent specialist?
And my wife and I were we were kind of done with being in the big city. So
Philadelphia's tough to get around.
Philadelphia's we lived in the center city, right in the middle of everything. And it was fun for 9 years, but it got old. So we were I'm from Pittsburgh originally, so we were looking to move back in the area, Western PA or Southeast Ohio. And I put out some feelers essentially with the other folks in my specialty who are around here and said, are there any good job openings? Is anyone looking for someone in my specialty? And they got me in touch with Dr. Smith, one of our great interventional cardiologists here, who has done a lot to really grow this program from the ground up and has really made this a great cardiac specialty hospital. And he had me come out here. We did a few interviews, and I just really bought into his mission and his vision for what this system is looking for, which is bringing like very highly specialized advanced procedures to an area that otherwise was pretty underserved before.
Yes.
You'd have to go to Pittsburgh or to Cleveland.
Yeah.
Because a lot of the procedures we're doing here, you couldn't even find in like Columbus.
Yeah.
So I really bought into that vision. And he had already gotten a lot of great technology that I use. So it was almost like a plug and play kind of system. So
yeah. I talked to him a little before speaking with you, and the one thing that they're all about, Dr. Smith and Dr. Suero, is new procedures and new technology. And one of the things you mentioned to me when we were chatting before this was you are passionate about new procedures and new technology. So give us a window into, and I know that's one of the reasons why you wanted to come here and why they wanted you here.
Sure.
So what are you going to bring to the area?
So there's some things we've already brought to the area, which is great.
Yes.
At Trinity, there's already 2 new procedures that we did since I started here that we had not done before. So one of those procedures is something called a leadless pacemaker. Do you know anyone that has a pacemaker?
I sure do, yeah.
And they have this lump under their skin.
Yeah.
Just hitting my microphone. And they have this lump under their skin, and that's where the battery is, the computer is for the device, and then there's wires that travel through their bloodstream plugged into the heart. And it can be a pretty visible lump in skinnier people. And in the last decade or so, one of our companies has developed something called a leadless pacemaker, which is a little guy that's about this big, almost the size of a bullet, and it plugs directly into the heart with no wires. So the benefits of that are, there's no wires that can cause obstruction of your blood vessels at a time, or even get infections could live on that. The other benefit is you don't have this big hunking thing under your skin that some people can really be bothered by. It can be hard to sleep on that side sometimes. I put my first one in about 3 weeks after starting here, which was the first one that's been put in at Trinity. And I shouldn't say the first one I did. I've done quite a few.
Yeah, right. But it was the first one.
First one here at Trinity, and we had to get approval and everything, and it was for someone who was in the hospital that really this was the right device for them because they were at risk for infection, and so the hospital was great about getting rapid approval of the device and getting everything lined up. And since then, we put in around 6 or 7 of them and have a few more on the horizon.
The amazing thing that I'm hearing about that is you'll barely know it's there.
No, you wouldn't know it's there.
Yeah.
And the only thing, if you felt really bad before you got it in, you'll all of a sudden feel a lot better because your heart rate's gone from 30 to 70. But other than that, you'd have no idea it's there unless you get a chest x-ray and someone says, hey, what's that? What's that?
Yeah, it becomes almost a part of the heart.
Yes, the heart actually grows around it over time.
No kidding. That's fascinating. It's a testament to how our body just adapts.
Yeah, absolutely.
That's an exciting piece of technology.
Excited about that.
Can't emphasize that enough. Because people, they're relieved when they have to get a pacemaker, but then there's a whole learning curve that goes into adding that into your life.
100%.
Not just with sleep, but yeah.
Well, they used to not be able to go near microwaves.
Right.
Not the case. But there's a lot of kind of stigma that can come around with that too.
Yeah.
And a leadless pacemaker isn't for everyone, but for the right patients, it's a great technology.
How did it feel when you completed your first surgery here?
Here. I think I was just relieved when I was done because there's just, especially with my specialty, there are a lot of moving parts. There are company representatives that come in to help us with the devices we're putting in. It's my first time working with the nursing staff here, and I'm always leery working with a new team. I don't know how good they're going to be, but I mean, everyone worked smoothly. Everyone was coordinated. We had done a lot of briefing ahead of time. So once I finished my first case here, we felt good.
That's awesome. So we now have, you said you've done 6 or 7 since then. So that's 7 or 8 patients whose lives you've impacted. What are some other procedures? What's some other technology you're looking?
Another cool,
either that's already been introduced that you can enhance, or you're going to introduce.
Yeah, another new technology that again is new to Trinity that a few doctors are doing in the kind of greater like Pittsburgh area is something called conduction system pacemaking. So traditionally, talking about pacemakers again, they would put one lead in the top chamber of the heart and one lead in the bottom chamber of the heart. And people wouldn't pay a lot of attention where they put those leads. As long as it was stuck in the heart, wasn't moving, you'd consider that a success. And for 30 years, that is what pacemakers were.
Yeah.
Over the last decade or so, we've recognized that if people are paced a lot from their bottom chamber of their heart, the heart weakens over time. Because the pacemaker itself just activates a local clump of cells.
Yeah.
It's not really part of the electrical circuitry, your heart's normal electrical circuitry. So instead of having your heart squeeze all together and make a nice clapping sound, one side of the heart would squeeze first, and then the other side of the heart would squeeze. So instead of getting a nice clap, you'd get a little bit of a almost delayed kind of thing.
Yeah.
So some clever electrophysiologists about 5 or 6 years ago started putting these leads in your heart's normal electric circuitry. We call it the left bundle branch area, fancy term, but it's this part that's kind of in the middle of the heart, and it's kind of hard to get to. So some of the device companies that help us out designed some special sheaths, essentially, to let us target that exact part of the heart. And we can actually drill pacemaker lead into your heart's normal electrical system. So instead of pacing a random clump of cells, we can actually kind of hijack this heart you were born with and can get past that area wherever your block developed, and instead can get your heart to squeeze like it's supposed to. And we've had amazing results with these cases.
That's
amazing, yeah. For nowadays, any new pacemaker I put in gets one of these leads.
Yeah.
It takes maybe an extra 10 minutes than it used to, but well worth it for a lifetime of not developing heart failure. And some patients, I will upgrade their old system to one of these like new systems. In fact, the last case I did right before joining you was taking a patient who had developed heart failure because the lead was in the wrong place and put one of these new leads in, and I can't wait to see her in 3 months. I bet she's going to feel a lot better.
It's remarkable. It's so interesting that when it started out, which it was revolutionary technology, as all technology does,
absolutely.
There's just that enough of it that they don't understand. So they're like, well, as long as it's in there not moving, we're fine. But you've since found you can actually hijack. I like that word, hijack the electrical circuitry of the heart.
And it's the kind of thing where when the first doctors started doing that at like, NYU and University of Pennsylvania, when they first started doing that, everyone else kind of thought they were crazy.
Yeah.
Like, why are you it's going to take you forever to find that. And it's going to take forever to get your lead there. If you're going to
10 extra minutes.
2 or 3 hours. Yeah, it turns out. At first it did. At first it took them a long time. But the results were so good, it kind of prompted the companies to make us better tools. And yeah, now it takes 10 minutes more.
I've asked some of your colleagues before, what are some of the innovations you see on the horizon that you're excited about?
One thing I think is very interesting. So we talked a lot about pacemakers. The other side of my job is ablations, which is where I burn the inside of your heart out or freeze it or something like that. So that is really fun.
You just made it sound really scary.
But
Gonna burn or freeze.
Burn, freeze. And one new technology that I'll talk about, but this is for like people with fast heart rhythms to treat that kind of thing. So instead of a slow heart rhythm, looking at the people with fast heart rhythms. Atrial fibrillation is one of the most common fast heart rhythms that I'll help to treat. And right now, for years, all we've done is burn or freeze to get rid of AFib. One technology that's on the horizon is something called pulse field ablation. PFA is kind of the shorthand for it.
Sounds friendlier.
It does. But it doesn't. What it actually is high voltage, like electrocution of the heart, which sounds, again, crazy, but this is very safe. And it's actually safer than burning or freezing your heart.
Yeah.
At least that's what studies are showing us. What we don't yet know is if it's as effective as doing the burning or freezing. So that is something I'm eagerly awaiting the results for. But at least behind the scenes here at Trinity and our greater health system, we're already kind of getting the ball rolling on potentially getting one of these systems and starting to use it to provide faster and safer ablation. My question is it as effective? I think it will be. And I'm very optimistic about what the future holds. This is something that only got developed about 4 years ago, so we're in very early stage.
I'd love to talk to you again as you find out more information about that. That sounds fast. We hear a lot of talk in the mainstream about artificial intelligence, AI. Where is that? It has to be in the medical field, like it has to.
Oh yeah, absolutely.
So how is it impacting your line of work? How is it improving? What are some of the hopes you have?
I think the biggest help we're going to get from artificial intelligence is going to be in waveform identification. Sounds fancy, but what it basically means is anything that involves a wave can be easily scanned into a computer, and a computer can easily compare it to its huge body of evidence, because that's all AI really is. You put a bunch of data in, and then you can put in new data, and it can find what it's most similar to, essentially. And
best way anyone's ever explained.
That's the way. My brother's a computer scientist. Does a great job teaching me about this stuff too. So I think EKGs, my favorite test, are one thing that AI is going to be much better at reading. Because right now our EKG machines often come back with erroneous reads, but I think AI is really going to enhance that. But also, if you're sent home with a heart monitor for a couple of weeks, it'll be able to read that faster and more efficiently. It'll be able to read if you get a pacemaker or defibrillator, you go home with a little thing you plug in by the bedside, and that transmits data to us. That's going to help us out too. Yeah. And if you have a defibrillator, its job is to recognize abnormal heart rhythms and shock the right heart rhythm.
Right.
AI is definitely going to help us identify when's the correct time to shock someone and when's time to just...
It's exciting to be living at this. I mean, so exciting, I just stuttered. But it's exciting to be living at this time in history.
Yeah.
I mean, this is stuff that the geniuses of the past could only dream about. Mm-hmm. It's just remarkable.
That's exciting.
Is that the main reason that you love your calling and you just love to see the innovation and how it changes people?
Especially electrophysiology. I mean, every year there's something new that someone's developing, and you just, sometimes you're like, we'll see, maybe. And sometimes everyone's just like, yes, why didn't we think of this before? This is amazing.
That's incredible. What do you hope to offer the patients of the Ohio Valley, both from an interpersonal perspective and a specialist perspective?
Well, one thing we've already talked about is just having high complexity procedures in your backyard, so you don't have to travel all the way to Pittsburgh to be able to get some of this stuff done. A lot of electrophysiologists work not for just one hospital, but will serve 9 different hospitals in a region, and it can be a little harder to get individualized care, if that makes sense. I am Trinity's electrophysiologist, and this is where I come to work every day. This is where you can find me. So when, patients need that personalized touch, I know you. And one thing I love about working here so far is that this is where patients come to go for all their doctors. So I'm not having to check 1,000 electronic medical record systems. I have all the information at my fingertips. So when you come to see me in the office for the first time, I've already researched you for a half hour and know everything about what everyone else has said. And we can skip some of the pleasantries, if you will.
Yeah, absolutely. I mean, that's terrific. Is there anything else you'd like to communicate to our audience? I believe we've covered the new procedures and technology. We've talked about AFib. By the way, AFib is one of those things that my experience, whenever someone is diagnosed with AFib, there's kind of like, well, I've got AFib and they've given me this stuff, and there's almost a resignation to the psychology behind it.
It's an interesting way to put it. My dad was recently diagnosed with AFib too. He doesn't come to me. I give him advice. It's the kind of thing where it's very common, especially in older populations. And, having high blood pressure, having heart failure, having leaky valves can make you more likely to have AFib, but anybody can develop. Because it is something that just happens as you age. You get scarring in random parts of your heart, and that can ultimately trigger atrial fibrillation. When I was in medical school, they taught me that, well, if they're in AFib, just keep their heart rates low, and that's fine. But we've come to recognize in the years since then that really, if you're diagnosed with AFib, we want to try to keep you in a normal rhythm. Because long-term, you will do a lot better. Because the more time you spend in AFib, the more likely you are to stay in AFib. And if you get to, if you're in the early stages of being diagnosed with AFib, I think it's really important to see a cardiologist or even see an electrophysiologist, because we have a lot more treatment options than we used to have to keep you in a normal rhythm. And if we get to you early enough, you're much less likely to have a progression of your AFib as life goes on.
Especially nowadays, with all the progression we've been talking about, all the innovation, it sounds like it's best, if you're a patient who's gotten a very serious diagnosis, it's best to keep asking questions.
Oh, 100%.
Yeah.
Communication's key. I mean, there's a reason that...
Don't just resign yourself.
Yeah, I mentioned I like to be able to spend time in the office with my patients. One of the nice things about my specialty, I'm not just in the operating time. I consider my job, and I tell patients this in the office, my job is to educate you and teach you what all this is. You didn't go to medical school and do all this training.
Right.
But like I did, let me bring it down to earth for you and make this seem less of a nebulous or even scary thing.
You do a great job doing that.
Right. But in AFib in particular, we talked about ablation. 6 years ago, we would only really look at ablation as something of a last resort, a little bit risky procedure, something you don't want to do in everybody. Nowadays, it's something it's become so safe. It's something I offer to almost anyone who's ever had to be shocked for AFib before. I would say, let's talk about ablation. It might be something reasonable for you.
Well, thank you for stopping by, introducing. It's nice meeting you, introducing yourself to the community, and I really appreciate you sharing it and your ability. I mean that, your ability to explain these complex innovations and technologies. I mean, as I was listening to you talk about it, I was getting excited. I was like, that's because, and I'll tell you, my family has a history of heart issues. So, that's one thing I'm aware of as I get older. So hearing that there's innovation.
New stuff every year. I mean, between what the interventional team here is doing with some fantastic new procedures that often coincide with what I'm doing, like left atrial appendage occlusion, I know you've talked to other folks about, where we close up the little part of the atrium that blood clots tend to form in. That can go hand in hand with an AFib ablation nowadays. So it's amazing some of the stuff on the horizon.
Well, thank you, Dr. Kloo. It's been wonderful meeting you.
It's been great to be here, and I've felt very welcome so far here at Trinity.
We hope you continue to feel that way, and we can't wait to see what you do for our patient community, and we hope we give you a lot of love in return.
Fantastic.
Thank you for joining us.
Yes. Great to meet you.
And thank you for watching. We'll see you again next time.